More like some real estate developments where you're, developing from the ground up. When you're doing medical device development, it is a lot like drilling oil wells. You can have a bust or a boom, and there are more people who lose more money than make money in medical device technology.
This is my time.
Hi, I'm Kyle Stevenson, and you're listening to the Assets in Orthopedics podcast. In this forum, we hope to educate medical students, residents, physicians, and other high-income professionals on the power of investing, especially in real estate assets and syndications. We want to help providers gain financial intelligence with the hope of earning financial freedom. Please listen and learn so you can spend more time doing what you love with who you love. Enjoy the podcast.
I go 100 all day.
Hello and welcome to the Assets in Orthopedics podcast. This is your host, Kyle Stevenson. We are excited to welcome our next guest. He's an orthopedic spine surgeon and entrepreneur, Dr. Jim Marino. Thank you for joining us here, sir.
It's my pleasure, Kyle.
Dr. Marino, I will introduce you first. Just give you a little bio on you, and then we'll let you kind of wrap that up and fill the gaps.
I'll give you a quick kind of thumbnail of my life experience. I was born in the Bronx in New York. My parents were both first-generation Americans, both born of Italian immigrants. I had three brothers, two of whom became physicians, one became an attorney. We spent most of our youth in a suburb of New York called Teaneck, New Jersey, which was a fantastic place to grow up in, sort of the early to mid 50s and early 60s. It had a very diverse group of primarily first and second generation Americans post-World War II. Great schools, great public schools, strong emphasis on education, and lots of parks, lots of safety, plenty of activities that were sponsored by the community and the township. It was a suburb. Everybody had a small home, small plot of land, little backyard, and we got together and played ball in the schools, schoolyards, and the parks after school. I finished high school and decided to go to Tufts University for a variety of reasons, but primarily to see if it would help me socially, because it was a co-ed school, and I thought, I need a little help here because I wasn't that, I didn't have the particular aptitude in high school to meet young ladies. And when I got into college, I decided, I have enough advanced placement here. If I really work hard, I can probably get through in 3 years, and I can probably do a double major in chemistry and biology. And that kind of limited my social experience. I finished college, and then I applied to med school, and I got into Howard University, and it was a 3 years honors program. I finished in 3 years and then started my internship and went straight into residency and achieved board certification before the age of 30. When I was in my training, arthroscopy was the new big thing. Arthroscopy really took off in my residency at a rate that the attendings really were not all up to speed. We were learning from community physicians and from a few of the allied physicians who were oriented toward minimally invasive arthroscopy and sports medicine.
So was that late 70s, early 80s? It
was definitely late 70s, early 80s. I finished my residency in 84.
Okay.
We were doing, early arthroscopic interventions on primarily the knee, partial meniscectomies, loose body removal. We were doing plica excisions at the time and, a few other things. But the field was rapidly evolving. So as soon as I was out of my residency and in, clinical practice, and of course, going to a variety of courses, I was doing shoulder arthroscopy. I did elbow arthroscopy. I did ankle arthroscopy. And so I was really enthused about the power of this minimally invasive technique and its broad applications in the peripheral joints. But my patient population was predominantly low back pain and sciatica. So there wasn't a lot of application for arthroscopy in that patient group. And I made an early and I think a smart decision. I said, look, I'm either going to be a triage orthopedist for all these people with back pain, or I'm going to focus on an area of spine, become as knowledgeable and proficient as I can, and decided to exclusively engage in degenerative lumbar spine surgery. And I attended all the hands-on courses and didactic sessions that I could, everything offered by the American Academy of Orthopedic Surgery and NASS. And it went to not only the annual meetings, but also to regional meetings, and really looked for particularly meetings that involved cadaveric work and hands-on surgical experiences under mentorship. And I also made myself very available to those spine surgeons with a good reputation in town who were looking for assistance, and tried to do my best to acquire some of the skills that would then be utilized for the rest of my career. And while I continued to do general orthopedics, it became less and less a part of my practice. I mean, I did everything from total joints to advanced trauma. It was on several level 3 trauma systems. But eventually it became primarily elective degenerative lumbar spine. And I enjoyed that. But I also wanted to see if I could bring some of the technological advancements and techniques that were applied in arthroscopy to spine. And I saw that, spine was a sort of maximally invasive type of procedure in the early parts of my career. We were basically filleting the back open, and we were disrupting a lot of very healthy structures in order to get to the pathology, which was, deep in the spine. We're trying to decompress a nerve root, but we got to move a lot of muscle and intersegmental ligaments and resect this and that in order to get to these nerve roots. So I saw that there were some early pioneers. A person in particular I give a lot of credit to is a gentleman who worked at the Graduate Hospital in Philadelphia, Pennsylvania, a fellow named Parvis Cambin, the fellow who Cambin's triangle was named after. And he was doing arthroscopy on lightly sedated patients, primarily to do disc resections. But there was some early work on foraminal decompression that he was advocating for. And so I attended his course and saw that while Dr. Cambin had done a great deal to advance this particular area, that there was a lot more that could be done, particularly if you could fully sedate the patient and use neuromonitoring as a means of protecting nerve roots through evoked potentials and electrified cannulas. And I also saw the advantages of stereotaxic or, guidance for placing these instruments, expanding cannulas. There was a lot of things that I could see that just needed to be developed, and I was trying my best as kind of a surgeon inventor to advocate for some of these concepts, and brought some of my initial ideas to an arthroscopy company called Acufex. Acufex was at one time the leader in arthroscopic instrument fabrication. They were out of Massachusetts. I don't remember if it was Mansfield or some, but I went to Acufex. I showed them some of my ideas. They thought that was interesting, and they started developing some early instruments for me. But their initial interest waned because they ended up selling off their division that was spine oriented.
Okay.
And I got back all my ideas, but I didn't have a home for them. It was shortly after that through more serendipity than intent, I was introduced to a physician who became a venture capitalist. He was no longer practicing. He was an obstetrician gynecologist who became a venture capitalist, a fellow named Drew Senye at Enterprise Partners in San Diego. And he asked me to describe some of my ideas, thinking that, okay, well, let's just see what he has. And when I was through, he thought, well, there's enough here. I want you to summarize it. And after I did that, he invited me to get on a plane with him and go visit Kleiner Perkins Caulfield Byers, which was a major VC group up in the Palo Alto area. We met with Joe Lacob, who is now the principal owner of the Golden State Warriors, also a owner of Pebble Beach.
Okay.
So he did pretty well.
That's amazing.
Yeah, he was doing extremely well from a financial standpoint because they were involved in financing Google and
oh my gosh,
eBay and a variety of other startups in the Bay Area. They did extremely well. They thought some of the ideas, or he thought some of the ideas were interesting. They asked me to present to a intellectual property patent attorney, and he said, yes, I think we can protect these ideas. And then the next thing was a meeting before all of the partners at Kleiner Perkins in front of the head of the spine program at UC San Francisco. And after I did the presentation, they dismissed me, and they asked the opinion of the very highly regarded spine surgeon from UC San Francisco regarding my ideas. And he basically said, I don't really think there's much there. I wouldn't invest in it. And then they dismissed him and they invited me back into the room and they said, we never do this, but we're going to go against the advice of our expert.
Okay.
And we're going to invest in your ideas because we think they're appealing. And I think also the ideas may have been fairly general, but they saw that the market potential was large. At that time, there was really just Medtronic, which was focused in spine, but there really weren't any other companies that were primarily spine oriented. There were large orthopedic concerns, like the J&Js and Hughes, et cetera, but there really weren't any major spine focused companies, exclusively spine focused. So that's how it started out. We had some of those ideas formalized and presented to academicians around the country who thought that, yes, there's enough here and they would be interested if these ideas were developed. And so they said, okay, we're going to start a company. What do you want to name it? And I said, well, I like the name NuVasive. And so they took that name and I was the first president, but I didn't act in that capacity for very long because they asked me if I wanted to be CEO, and I said, I'm a surgeon inventor. I'm not a businessman. Let's put this company in some, competent hands. And they did end up hiring initially Jim McKinley and then subsequently Alex Lukianoff. And anyway, the company did pretty well thereafter. And I segregated from the company around 2002. Anyway, that's kind of a summary of my personal and business experience outside of my clinical practice.
Okay. Yeah, let's go through a lot of that. So yes, as you mentioned, you were a spine orthopedic surgeon, correct?
Yes.
And you're an innovator, an inventor, which there's not a ton out there. That's really cool and it sets you apart. And it reminds me a lot of Homer Stryker. And I kind of want to get into that. But you're an innovator.
Did pretty well.
Yeah, he did very well. So minimally invasive surgery, you started NuVasive. And how'd you come up with the name? Was that something you were thinking about for a long time?
I thought of, no, it didn't take me long. I'm probably better at little slogans than I am at orthopedists. For some reason, I just kind of think, things that in my mind sound clever and might be, have a double or even triple entendre. And I saw NuVasive as that kind of a name, and it stuck.
Yep. And so a lot of this audience will be, medical students, residents, physicians, not necessarily just orthopedics. So I just want to explain NuVasive. It's spinal technology and procedures that ushered in subspecialty of minimally invasive spine surgery, correct?
Yes, they did emphasize, I would say, nerve monitoring and also particularly the transpsoas lateral approach to the lumbar spine.
So that's a big deal. Yeah, and when I think of, Homer Stryker, he was in residency, always on the back table, tinkering around with instrumentation and implants. And I'm not sure he even finished residency. I think he just started his company around that time and switched roles altogether. You were a practicing orthopedic spine surgeon, and you were doing this on the side, basically.
Yes, and I think for me, that was a great advantage in being an active spine surgeon because, it wasn't just ideas in spine surgery that I started having. I mean, I had ideas that applied to all areas of practice. When I'd assist in total joints and other things, I could see where, for instance, navigation for hip replacements would have a lot of value. I didn't share the same opinion with respect to knee replacements because we had very long osseous references in the tibia and the femur, but in the acetabulum, you really don't have much. You have visual cues from the transverse acetabular ligament, etc. But getting that orientation for the proper anteversion and inclination angle, I could see where navigation would be very helpful. And so I was always thinking about how to do things a little different and better. And one of my problems, as my partners used to say, is, Jim, you've never met a procedure you didn't think you can improve upon. And sometimes it's a fair criticism. I always thought that there was something that you could do that would make the procedure a little better. And, as long as it wasn't, I'll just say, excessively innovative, I would be advocating, on the table, well, why don't we do this? They'd be saying, well, why don't we just do it the way it's supposed to be done?
Yeah, right.
So I'll say there's some downside to having too much of an inclination for altering what is accepted and standard practice. And you have to be careful if you're an innovator to not exceed a reasonable modification, or you're really doing experimentation, which is not appropriate for customary usual practice. So
right.
Anyway,
you don't want to be a cowboy necessarily and do things off the.
Yes, exactly.
Yeah. But to that point too, with not experimentation, but more scientific studies and making that evidence, you have to test, fail, and prove. Right? Test, fail, learn, and prove.
And obviously, all of medicine is advancing through innovation. And if you have the interest and, if you will, the aptitude for it, you could make great contributions in your field. Even, as a practicing orthopedist, if you come up with some better way to address a particular problem. And it can be technique and it can be instrumentation. Some of it is not always lucrative. I can remember doing a acromioclavicular dislocation repair. We were using some kind of technique where we were placing, I think it was Merceline tape around the clavicle or through some drill holes in the clavicle and under the coracoid process. And after I was through and the operation went well, another orthopedist came up to me and he says, well, what did you just do? I said, well, I did a AC dislocation repair. He said, well, was it tenting the skin? I said, well, yeah, but it wasn't sharp. He said, well, why didn't you just leave it alone? I said, well, I don't know. I think, it's common practice to repair those. And he said, well, have you ever had to do a late repair? I said, no. He said, did you ever see one? And I said, no. He said, well, what happens when you have to resect the distal clavicle? How bad is that for the patient? I said, not bad at all. He said, well, why don't you just leave it alone? And I thought about it. He was right. I left them alone after that. And I don't remember having to do a late reconstruction or a late repair. But if I had to, I could do a distal clavicle resection. It wasn't a big deal. So I think some innovation is just simply, just being thoughtful about, how often do you have to do, late, medial collateral ligament repairs as an isolated procedure. Yeah, obviously, if they're associated with ACL deficiencies, you're going to address the problem that does need to be addressed. But the medial collateral ligaments, they do pretty well on their own if we just leave them alone. So there was a lot of things that I learned that involved essentially just considering what the long-term natural history would be if you did nothing. So I recommend to the younger guys who are anticipating doing some procedures that they consider, okay, what's the natural history here and how much are we improving upon it?
Yes, definitely. Yeah, it's always first do no harm, correct? So
absolutely.
Do what's best for the patient. And okay, so getting back to innovation and you thinking outside the box and pushing the envelope on that, I feel like now every residency program, every fellowship, they really push research, right? And so research is almost bogged down a little bit. It's almost diluted because there's so much research out there. I don't know if, I think that's a bad thing for sure. And there are some programs that do much better than others. But in your mind, how do we keep that innovation spark alive? Because, medicine's always going to continue to evolve. I don't know. What would you say to that?
There's certain people who have this inclination. I was one of them. I mean, just to give you an example, when I just learned how to drive, I was driving one day at night and there was a guy I stopped on the side of the road and it was dark and there were no lights around. And I'm thinking, I can barely see this guy. So I said to my dad, I said, look, I'd like to paint the underside of the trunk of the car with reflective paint. He said, why are you going to do that? I said, because I think, if you just open the trunk, this is in the days when we didn't have a lot of hatchbacks. We had a lot of trunks. But I bought some reflective paint and, put it on the underside of the trunk and I opened it up and I could see that, wow, you could see this from a quarter of a mile, half a mile away. And so if you have this inclination to innovate and you're in the field of orthopedics, there'll be no shortage of opportunities to apply that problem solving, I'll say creative problem solving interest. And there are other people who have, I had partners, they had no interest in innovating. They were very good clinicians. They were great in their practices, but they didn't want to innovate. It was just something that was not something they had an interest in. So I don't think you can suppress innovation in people who are so inclined. They have to, probably the bigger problem and something that I learned a bit the hard way was that you need to temper your enthusiasm for innovation in order to be protective for not only the patient, but yourself. I know that a lot of people don't know this, but Paul Harrington, who is just one of the, pioneers in spine instrumentation and very famous for something called the Harrington rods, which predated segmental fixation, where you use pedicle screws. Those Harrington rods were extremely important in stabilizing spines for several decades before we had pedicle screws. And I was told by people who knew him that he almost lost his ability to practice medicine because, some of his rods at the beginning were not as great as others. Rods were breaking. And there were also clinicians who were envious of his, I'll say, maybe notoriety and the developments that he was advocating for. So anyway, I'm just giving you an idea of some of the things that an innovator might encounter. So I would say, just be cautious, try to be iteratively innovative rather than do it in a revolutionary way, because that you're just leaving safe harbor behind if you go too far out on a limb.
Yes. So real quick, I do have some questions for you, but I want to go back real quick because I had a nice bio that I want to just put out there just for the listeners so they can see all the things that you've been doing. As we talked about, Dr. Marino is an orthopedic spine surgeon, recognized innovator of minimally invasive surgery, And in 1997, founded NuVasive, as we talked about, where he invented and developed spinal technology and procedures that recognized commercial success and ushered in the subspecialty of minimally invasive spine surgery. You also founded Trinity Orthopedics in 2004. Yes. And that is where you are continuing to develop and commercialize.
I have to say, so this was a business experience for me, and I think maybe some of your listeners would profit from my losses here, so to speak. I tried to self-fund this company, and that was a very difficult proposition, not only because my personal wealth was insufficient to do the company justice, but I also had too many ideas that I was trying to finance. I wanted to do too many things with too little money. And it became evident to me after expending quite a few $1 million that I was not going to be able to sustain it. And we were not finding outside financing to supplement what I had to offer. So we had to do, as it's referred to in business, as a pivot from our more ambitious objectives to a much more achievable and sustainable objective. And one of the ideas I had, which was to advance autologous bone harvesting in a minimally invasive way. I developed a tool with the help of some engineering that we call the COREX device, which is a percutaneous pantsless autologous harvesting tool. And it is an extremely efficient and very effective tool that essentially minimizes the donor site morbidity, which had been the previous primary reason for considering alternative biologic offerings. And while we have a very successful tool and it's been used tens of thousands of times, it's grossly underutilized, in my opinion, because we know that autologous bone has had 100 years of published clinical results in a broad variety of applications by authors who were not financially incentivized by autologous bone harvesting. It was essentially commercial-free, promotion of the use of autologous bone. And unfortunately, the complications of open harvesting are substantial enough that it prompted the use of alternatives, initially infused, of course, a variety of allograft tissues, and then some of the cellular bone matrices. If you look at the literature on the cellular bone matrices, particularly the review literature where they do systematic review, there's really, in my opinion, and I think it's founded on the results of these studies, there's no data that is sourced from unbiased or potentially conflicted sources to justify the use of these very expensive alternatives. There's just no data to show that these mesenchymal stem cells are actually actively producing bone when transported in clinical situations, or that they produce more bone than just simply allograft with DBM. And yet they're a premium priced product. They're very prevalent. They're very, I'll just say, much regarded as a reasonable alternative to autologous bone graft, but the data doesn't substantiate that. And I don't think you can cost justify the use of those products. So I would say you have to go back to considering the autologous bone harvesting in a minimally invasive way in which the donor site morbidity is trivial or absent. And unlike infuse, which has the graft site morbidity from, osteolysis, end plate resorption, implant subsidence, heterotopic bone formation, neuritis, autologous bone doesn't have those graft site complications. And yet the Yoda study, which was a compilation study from Yale, showed no statistical difference in fusion rates between infuse, BMP2, and cancellous autograft. So I think there's an opportunity for surgeons to reconsider, if you will, all of the biologics and reconsider autologous bone harvesting in a minimally invasive way, which our COREX device does.
Yep. And I saw the video. I saw it on your website. So you have dozens of U.S. patents in orthopedic technologies, correct?
Yes, many.
And the COREX bone harvester is just one of those.
There's several patents associated with that, yes.
Okay. So where are you guys marketing this and getting that out there?
Well, we're doing a little of it right now. So,
Yep.
I mean, without being shameful in my self-promotion.
Absolutely.
The company is Trinity Orthopedics. You can look online for COREX bone harvester, and we have a variety of videos showing harvesting from the proximal tibia, the iliac crest. It can be used, obviously, in the calcaneus. I mean, most people who see it say it's impressive. We've had companies try to acquire our device and call it, the best in class. So I think it's something I would say if a surgeon is willing to consider autologous harvesting, I would hope they would just spend a little time and just look at the Trinity Orthopedics COREX bone harvester website and consider using it in future procedures. There are other things I'd like to pursue, but again, financial constraints are a reality that as a surgeon inventor and now as mostly an inventor, you have to consider. It takes a lot of money.
Yes.
To not just develop a prototype that works, but to develop a product and get it out in the market and advocated for.
Right. So what about the private equity groups that you were working with before? You're in the perfect area, San Diego, right? There's a lot of startups and good money out there.
So there is some money. I mean, right in our area, I would say primarily you're not going to find a lot of the VC groups investing in early stage concepts. They want to see, the VCs pretty much want to see the traction in the marketplace. Okay. There are, individual investors who will invest early in ideas, and you can find them in a variety of locations. But for the more substantial money, you pretty much have to have some traction, unless the idea is just so appealing in theory and in some early demonstration project. So that's what I'd say. But we may get some more money in the future from outside sources, but we're trying to fund most of what we do through our own revenues.
Okay, that's great. Yeah, so I was really excited about this podcast because we've had a lot of real estate investors on, and so it's nice to have entrepreneur, innovator, inventor like yourself.
Yes.
And we talk a lot about, the financial aspect of things. And, of course, we could all just be physicians and put our head down and work in that realm. But, it's nice to have outside sources and you be able to use your creative juices, for other things. So
I would say perhaps more like some real estate developments where you're, developing from the ground up. When you're doing medical device development, it is a lot like drilling oil wells. You can have a bust or a boom. And there are more people who lose more money than make money in medical device technology. It's just, there's so many factors to consider. First, is whatever your idea sufficiently unique that you're not going to be violating other people's intellectual property. That's a big consideration. You'd be surprised. I mean, almost everyone who gets into this field and innovating will be astounded about how many good ideas have already been patented.
Yep. And
how many are close perhaps to what you have in mind. Another thing is, beyond the intellectual property challenges, some ideas just are very difficult to make work. And you may spend a lot of money in the prototype phase, and not end up with a marketable product or marketable concept. And then there's tremendous competition in this area. So your idea may be very good, but in the 3 to 5 years it takes to develop it, some competing idea will supersede yours. And these ideas don't come cheap. I mean, I remember one finance guy telling me, he said, I usually think that a device company, even a single device company, it's about a $25 million investment. This was quite a few years ago.
Okay.
I'm sure it's more like 35 million.
Yeah.
So it's some pretty big money involved. And if you don't have the financial backing to advance these ideas, you got to find that before you really start pursuing them, or you can lose your shirt.
Sure. So, there's Shark Tank is a big show that's on TV, right?
Yes.
It's not as easy. They make it look so easy. Like, oh, you just invent this thing and then, go on Shark Tank. Not so easy.
No, it isn't easy.
Yeah.
Getting the attention of the investors is hard. And then the obviously these people who are on Shark Tank have a great deal of experience, and they can avoid many problems, and they can also sort of take advantage of some of the other companies that they've started to piggyback some of the newer ideas onto, which can be an economical way to get into the marketplace.
Yep, that's wonderful. What things are you working on now? Is there a passion project of yours or another innovation that you're coming up with?
I have a few. I have a few that I would like to advance, financial conditions allowing. I've always been interested in a non-fusion approach to juvenile and adolescent scoliosis. I think there's an area for opportunity in which I'll just say one could hopefully modulate growth in a manner that would correct for deformity and be titratable. I think that's an area for tremendous opportunity going forward. And I also think there's opportunity for a wholly intraosseous interbody fusion that I would like to be involved in. I'm also interested in low-cost technologies. There's a great deal of emphasis on value, and value is a function of cost relative to benefit. I think there are ways to reduce costs, particularly in navigation technologies, so that they become, as one surgeon once told me, he said, try to make whatever you do cost little more than a drape, and it'll be adopted pretty readily.
Oh, yeah.
So I think there's opportunity for hip navigation that would be at a cost level that would be, a little more than a drape.
Wow.
And doesn't involve preoperative imaging and a lot of, I'll say, pre or intraoperative types of registration. So, I mean, I've got a lot of things that I'd like to do, and but again, there's sort of a limit financially on what our little company can do, and we'll see.
Yeah, it seems like you have a lot of these ideas, which is great, and who knows if you have the time to do all this stuff, right? That's a lot of stuff.
It's a lot of stuff, and I'm also, as I said, I'm not really although I've started a business or two, I'm not really a businessman.
Okay.
And I'm not really a guy who goes out and gets money. I mean, the Trinity was pretty, I'd say NuVasive I was very fortunate that I just happened to hit the finance guys at the right time with some good ideas in an opportune market. But I haven't been as successful with some of my other ideas, and I'm not quite sure why, but some of it, I think, has to do with my business savvy. I grew up with, my father was a physicist. He wasn't a businessman. So I learned more about physics than I did about, commerce. Let's just put it that way.
Yep. Have you ever read the book, Rich Dad, Poor Dad by Robert Kiyosaki? Okay.
I didn't.
Yeah. The Poor Dad is the academic, the intelligent one, right? That pays most taxes and apparently does stuff the right way.
I can imagine.
Yeah. Yep. what you need is a young understudy who's hungry and has that same brain of yours that could come in and help you with, pushing these ideas.
You're probably right. Or a business partner
Or a business partner with some money.
Capital.
Yeah. Oh, yeah. Yeah.
That would be very helpful.
That would be fantastic. I like that. You're raising capital right now as you speak. It's all about just getting those ideas out there.
We'll see. Thanks.
Yeah. Yep. Couple more things I want to talk about. First of all, young physicians. So I told you my audience is medical students, young residents, physicians.
Yes.
And I thought it was just young, but there's really physicians of all ages listening to this. What advice do you have to them just with anything? I would tell you, with young physicians coming out, loans are high, interest rates are high, so it's hard to buy a house. They feel very middle class. I think there's a lot of frustration and a lot of burnout going on in medicine right now, and you're kind of seeing it from a different perspective. So it would be interesting to hear your thoughts and any advice that you would give to any physicians now or in the future.
So I may have to be a little both philosophical as well as practical here. Your training and the effort you've put into it and the talent that you've brought to bear in your training will unfortunately not be necessarily recognized or rewarded for many of you. For many of you. For some it will, but for many of you it won't. And this can be a source of frustration. And I just want to say that you should try your best to satisfy your own personal self by knowing that you're doing good, you're doing your best for the patient's sake, and that you need to fulfill yourself through other than, I'll say, economic means. Mm-hmm. And so try to find things in your life that are gratifying, that bring you happiness and fulfillment in addition to your practice. Mm-hmm. De-emphasize, if you will, the financial portion in terms of your priority so that this frustration doesn't lead to bitterness. So I'm just giving you that because some of you, I'm sure, will succeed and some won't financially to your expectations. And I can say from personal experience, in the competitive marketplaces, sometimes the people who succeed the most financially are not necessarily the best physicians, and they often have what I would call loose indications for surgery. And you want to be able to sleep well at night. You want to be able to clearly examine your conscience and say, I did the surgeries for the benefit of my patient to the best of my ability. And, I never did anything to anyone that I wouldn't do on a relative or a close friend. So I'm just saying, understand that this is kind of the reality of medicine now. It's become an industry in which the physician is often an employee. And if you're not in solo practice or not in private practice, and you don't have patients, knocking down the door and you're an employee, okay, take a little bit of an employee's attitude and say, okay, these are my hours that I work and the rest are mine. I'm going to use them for my personal and my family's benefit. And when I'm on the job, I'll do a great job. But when I'm off work, I'm off work. Mm-hmm. And so enjoy your lives. It goes by pretty quickly. When you get to be, as I am, almost 71 years of age, you look back and you say, God, where did it go? I spent a lot of time losing sleep at night, going to the ER at 2 or 3 a.m. for, undocumented immigrants, getting hit by a car mm-hmm. with multiple injuries, having to cancel my paying patients the next day, and, doing it basically pro bono. And I wasn't making a ton of money in private practice. I made some money eventually through my ideas and through innovation, but in practice, I didn't make a lot of money. And sometimes that was a bit frustrating to me. And I would say, for those of you out there who might face the same frustration later in life as your practices evolve, try to find other ways to fulfill yourself. And when you're doing your medicine, take gratitude from the good you do for the patients you see, and find other means of fulfillment. So that would be a long response to your question.
Yeah. Fulfillment is really a big part of life, right? Being able to sleep well at night, having peace, not chaos. I'm young in my career, but you're saying it's not all about the money, right? Necessarily.
If you're putting food on the table, if you're able to clothe your children and, have a reasonably, safe and comfortable environment, don't necessarily look at envy at the guy, 2 or 3 blocks away in a much bigger house who barely knows anything compared to your fund of knowledge, because that will frustrate you, without limit. And that kind of frustration can lead to bitterness and envy, and you just want to avoid those things in your life.
Mm-hmm. Yeah, hopefully we're all learning by now, especially with the social media aspect, that comparison is the thief of joy. There's no question on that. Seeing somebody else's life looks amazing, but you don't know what's going on there. And one thing that you brought up, I watched a video or something. It was anecdotal, but this guy had all the money in the world and was going on yacht cruises and had beautiful women around him and doing all the things that you should do with a ton of money, apparently, right? And
that sounds like a prescription for a disaster.
Right, right. So what he said is he was living this life, and as he continued to do it, he always felt this big void, and he just wasn't sure what it was. And he said, finally, he realized that the things in life that fulfill him and most people are actually free.
Yes.
Right? It's the connections. Yes. It's your, it's your faith.
I completely agree with you. Faith and family, those are the bedrock of satisfaction and happiness in your life. I don't know, joy may be a better word, but if you have a sincere and strong faith, and I mean a sincere faith, not just, attending things because it's what you feel obligated to do. And you have a great family life. Put a lot of work into your family life. You put a lot of work into your professional development, put a lot of effort into creating a very fulfilling family life. That will add much, much more to your life than you can possibly imagine. And so I agree with you, Kyle. Those are excellent recommendations that you made. Excellent.
Your point of view is fantastic. You've had an illustrious career, both in medicine and, creating things in medicine. So very unique perspective, and we really appreciate you coming on. Usually to finish the podcast, I have 4 questions for my guest. Yeah. So what book are you reading right now?
So this has to do with my faith. I'm a very strong Catholic. I wasn't always a Catholic. I was at one time probably an atheist agnostic, but I became a Catholic. And I'm reading Peter, the First Pope. And it's about essentially the papacy and the biblical basis and historical and traditional basis for the office of the papacy.
Wow, that's fascinating. I'll have to check that out. What advice would you give to your 25-year-old self? You were already graduated from medical school at that point, so.
yeah, I was halfway into my residency. Yes.
That's crazy. Yeah.
Yes, I remember. I was involved when I was an orthopedic intern, I was involved in a hand replant procedure that went for like 20 hours.
Oh, God.
The guy chopped off his hand at the wrist, and the attending looked at me. He said, how old are you? And I said, I'm 22. He said, what are you doing here?
Uh-huh.
He said, you should be in college.
Doogie Howser.
So anyway, all I can say is, okay, 25 years old. Yes, there's a lot of work to be done. Be patient with yourself. Recognize that, yes, your professional ambitions are super important and you want to put in the hard work now, because as you get older, it gets harder to put those long hours in. You get those late night hours become almost unbearable when you get to be into middle age. So do it when you're young and you can tolerate it. Don't spend a lot of time partying. It's great to have some recreation, but don't be ridiculous and, get yourself intoxicated and do things that you regret later. And try to find a person who has values that are comparable to the ones that you idealize to become a life partner. Put a lot of effort into that. There are very attractive people out there that, you'll find that you'll have an inclination to want to meet, but start screening them for values. Look for people who have values that you admire, because those are the people, assuming you have some physical attraction to them, those are the people that will make the best partners and spouses in life.
Yep. Fantastic advice. What is your definition of wealth?
Well, other than the, obvious consideration for financial wealth, personal wealth is a life where you feel it was well led. It was a life where you expended your energies and your time on things that were ultimately meaningful to you, particularly when you look back on it in reflection. And as you see yourself further and further in life, and even if you start accumulating some financial assets, ultimately, what are you going to do with that money? I mean, it doesn't buy you all that you really want. The wealth comes, again, as I believe, and as you stated, from the satisfaction you get in your family and the satisfaction you get from your faith and from the good you do. I mean, I'm not excluding those who are secular from doing wonderful things in their life and being very altruistic. So I would say, your wealth comes from those things that you can look back on in your life and say with some sense of humility that you are grateful to have had the opportunity to do those things.
Yep. Fantastic. And really this last question, I think we're kind of leaning into it now. So I've changed my fourth question and I like this one much better. Something I came up with recently. I think it adds a little deeper understanding of why successful people do what they do. So we talk about faith. Proverbs 11:25 states that a generous person will prosper. Whoever refreshes others will be refreshed. So if you could make a big impact by giving back, what would you do or what would you focus on?
So each of us has talents. They're not the same. And I would say, some people, we're not all going to be Mother Teresa's. She had a talent for giving herself to the poor that few of us are going to be able to duplicate. Certainly we can emulate her, but we certainly can't duplicate her in her devotion and her commitment in life. Try to figure out what your talents are. You do have some, if they're not unique, exceptional talents. And use those talents not only for your own personal benefit, but for the benefit of others. And sometimes a really great businessman can create a terrific business and create opportunity for employees and do wonderful things for people who participate in their company. And that's a great thing. So if you're a physician and have talents for caring for patients in a certain way, obviously don't minimize how much of a great contribution that can be. You don't necessarily have to go become a missionary in the third world in order to contribute greatly to your fellow man. You can do it right around your home and right around your community as in many capacities. So just use your talents for other people, and I think that will ultimately be a very gratifying life. Fantastic.
Jim, it's been a pleasure. You're doing incredible work. You have been doing incredible work. and you're making a large impact on in medicine, especially orthopedics. So we really appreciate you being on. Where can people find you?
Well, I mean, there are different ways to find me, but I'm not hiding anywhere, so to speak. But if you want to get in touch with me, you can certainly do that through the company, Trinity Orthopedics. There's a way to contact me through the company. I'm in San Diego. I live in La Jolla. You can look me up. And if you want to send me an email, I'll be glad to try to respond. My email address is the number 1 followed by my name, James F. Marino, Marino, @gmail.com. 1 James F. Marino @gmail.com. And I'll try to respond to anyone who wishes to contact me.
Yep, that's great. Hey, real quick, one thing I thought about earlier, you mentioned Pebble Beach, right? So were you able to play that course anytime you wanted, or was that
No, gosh, I wish. I've played Pebble Beach a few times, mainly when I was quite a bit younger. And, it's a great experience, but I preferred Spyglass.
Okay.
Yeah, Spyglass doesn't have quite the spectacular views of Pebble Beach, but I think it's just a better overall, all-around golf course. Very difficult, just wonderful. It's right there. Really like Spyglass a great deal. They're all super expensive, so it's kind of an indulgence. Right now, I'm going to be going to Monterey in a few weeks, but not to play golf, just to enjoy the scenery. Point Lobos, if you ever get to Monterey and you like natural beauty, go to Point Lobos State Park. Spectacular.
That's great. I love it. And when I'm out there, I want to play Spyglass one of these days. So maybe I'll hit you up and get you out there. Okay. Well, we appreciate it, Jim.
Sure, Kyle. Thank you. All the best to you and your listeners.
Thank you so much, sir.
This is my time. I'm on the rise. Can't hold me down.
Thank you for listening. If you found value in today's podcast, please leave a review so our community can continue to grow. If you would like to stay connected or receive a copy of your free investing ebook, please go to www.sharpinvestmentsllc.com, and that's sharp with a P as in professional. This is not financial or tax advice. Please consult with your financial advisor or CPA.